Hello, this is your primer of interventional echo. In this talk, we will familiarize ourselves with the field of interventional echocardiography, review key structural cases from an echo perspective, and highlight material that you may see on your echo boards. The early descriptions of the field actually come from this disease. These are classic echo findings of rheumatic mitral stenosis. And in 1984, in the first report of balloon dilation to treat rheumatic mitral stenosis, is a description buried in the methods of the using live 3D scanning to guide interventional procedures. We've come a long way in echo technology since 1984. This is a still image from the paper of a transthoracic image showing the balloon crossing into the mitral valve. This is a case I did in 2008 under 2D TE guidance, showing the balloon inflating the mitral valve. And this is a case I did last year. Real-time 3D anatomy of the entire mitral valve is visualized. And also in real time, I have awareness of the in-away balloon location in the left atrium. And I can use real-time 3D to guide the balloon into position. And percutaneous mitral valvuloplasty is still a model of interventional echo cases. Pre-procedure planning is done with TTE and TEE, and then the use of echo, whether it is TEE or ASE, helps to guide the procedure, evaluate for success of the procedure, and also evaluate for complications. And interventional echo really supports planning and performance of transcatheter interventions. The structural team is comprised of imaging colleagues, surgical colleagues, and cath colleagues. Interventional echo has a role in pre-procedure planning, intra-procedure planning, and post-procedure follow-up. And this is what a modern day lab looks like. This is a TMVR procedure in a patient with a failing bioprosthetic mitral valve. We can see echo, surgery, cath, all integrating expertise from each of their respective specialties under live 3D, TE, and fluoroscopy guidance to guide this mitral valve into position. With this interventional echo field comes additional considerations beyond routine echo lab practices. There's a very real risk of radiation to the performing echocardiographer who sits frequently at the head of the table, very close to the radiation source. There's staffing and scheduling issues that arise from cath lab and OR schedules. And then there's training of not only interventional echocardiography physicians, but also dedicated structural sonographers. The ASE offers you some guidance as a physician on the minimum competency required to obtain competency in transcatheter interventions. This is a document from 2019 outlining some minimum numbers on top of the COCAT certification for comprehensive echocardiography. And when people talk about interventional echo, they usually are talking about valve procedures. Interventional echo also supports a variety of congenital procedures, ASD closures, PFO closures, VSD closures, and also all of the electrophysiology related procedures, particularly LAO closure, which we will talk about shortly. And in the next section of the talk, we're going to approach 4 key structural cases, evaluating their indications, understanding the technology, and then demonstrating how echo plays a role in assessing, performing the procedure, and monitoring it afterwards. And really the watershed moment for interventional echo was the birth of TAVR. And TAVR is the first procedure that we will review. TAVR is now almost 20 years old. The first in-human TAVR was in 2002. The 2 most common platforms are the self-expandable valves, the core valve to Evolut Pro system, and then the balloon expandable valves, the Edwards Sapien systems. Both use a combination of stent that expands into the aortic valve, pushes aside the calcified aortic leaflets, and then the calcium from those leaflets will then embed into the stent, holding the TAVR stent in place. Over the last 20 years, we've seen indication expansion to where TAVR is now indicated in all levels of surgical risk, safety improvements, and yet still very similar hemodynamics, if not better than surgical valves. Echo is critical to TAVR. So the pre-procedure diagnosis of severe AS is discussed in other lectures, and the use of both echo and CT imaging variables help to make the decision about TAVR versus surgical valve replacement. The new ACC guidelines in 2020 use age as a guide, but then other imaging variables that would favor TAVR over SAVR for a particular patient. Once the decision for TAVR has been made, we then switch to interprocedure assessment. And the setup considerations in the cath and the hybrid labs are some of these. And just to sort of give you an example of what we do here at Aurora St. Luke's, you see here in this image a sonographer who's at the head of the cath lab table performing pre-procedure transthoracic images prior to deployment of the TAVR. Earlier, we had done TE and general anesthesia, and driven by sedation, interest in a more minimalist TAVR approach, we have switched now to transthoracic echo for almost all of our TAVR procedures. There are plenty of institutions that still use TE for TAVR. This is a nice table that summarizes the advantages to transthoracic echo over TE and vice versa, and some of the options to consider. In general, we use TT as a first-line approach for TAVR with a very low threshold to convert to TE if required. And once we decide TE versus TTE, we then turn to our baseline imaging. And this varies whether you are performing TE or TTE. The original TAVR trials excluded patients with left atrial appendage thrombus for TAVR. And so if we are doing TE, we evaluate for intracardiac thrombus. We also evaluate for any aorta pathology before catheters start being deployed. For TTE, you're limited in those two. And so you really focus on aortic valve function, aortic valve calcification, LV-RV function, and the presence of a pericardial effusion. And for the self-expandable valve, this was really a function of the newest iteration, the Evolute system, where the device could be entirely repositionable and recapturable should it be necessary. And so the 80% check for a self-expandable valve is really critical. When the self-expandable valve is at 80% deployed, the blood pressure is recovered, rapid pacing is usually turned off, and hemodynamics are stable. The valve has not been released yet. And so as an echocardiographer, one can evaluate the depth of the stent and with color Doppler, the presence of paravalvular regurgitation. We use both echo and fluoroscopy to determine if this valve needs to be repositioned or recaptured and then deployed again. And what do we mean by depth of the stent? Well, here's an example of normal, high, and low stent depths of the TAVR. In general, the TAVR stent should be 1 to 3 millimeters below the virtual aortic annulus and a little bit higher in valve-in-valve procedures. The risk of a high implant is embolization and coronary artery obstruction. The risk of a low implant is mitral valve impingement and conduction abnormalities due to injury to the pacing part of the heart. The goal after the valve is deployed is to then evaluate in the cath lab whether we need to do further interventions, another TAVR valve, a post-balloon dilation, and then the focus becomes, once the TAVR is deployed, understanding the function of that TAVR. So we've looked at depth already. We next look at shape of the stent. A circular stent suggests a normal stent that's fully expanded. Oval or D-shaped stents suggest that a stent is not fully expanded and can lead to abnormal leaflet motion. We next look at transvalvular regurgitation and leaflet mobility. An abnormal leaflet motion can be a sign of underexpansion of the stent, and transvalvular regurgitation is rare in TAVR. And so if you see it particularly early on, it is a sign of a leaflet abnormality that should be addressed before the patient leaves the cath lab. Spectral Doppler of aortic valve velocity can also help. Remember, velocities are slightly different on echo versus cath. But if the velocity is higher, it can be a sign that the valve stent is underexpanded, or in cases with small ventricles, very thick hearts, that there's some other type of subaortic obstruction that is present. And the final part of valve deployment is really paravalvular regurgitation. Why do we care about PVL? Well, PVL is an important marker of morbidity and mortality in TAVR, and really understanding and minimizing PVL before the patient leaves the cath lab will predict their long-term outcomes. We use this clock face that you see in a parasternal short axis view on transthoracic echo or a esophageal short axis view on TEE. And then using various different views, particularly for transthoracic in this graphic, you can see various parts of the clock face. Trivial PVL is less than 10% of the clock face. Anything from 10 to 30% of the clock face is generally considered moderate. Keep in mind, though, that this is just one parameter. Eccentric jets are going through crushed calcium and leaflets, and they don't always have a straightforward course. They may look like they cover a wide circumference, but they don't go out very far into the LVOT or the mid-ventricle. Perhaps the most important thing you can do, whether you do TE or TTE, is sweep through the TAVR valve upon deployment. You can see here that the sonographer on transthoracic echo is going from edge of the stent to the other edge of the stent, evaluating the location of jets, the number of jets, and then the extent of jets. PVL often requires a multi-parametric approach because it can be so eccentric. And it's hard to really quantify PVL in the interprocedural setting. Remember, in the cath lab, you just want to know, is there something that I need to do about it to minimize it before the patient leaves the table? So let's look at an example here. So this is an initial view showing one paravalvular jet after the valve has been deployed. When we sweep more posterior, we see that there is a second paravalvular jet. And when we sweep even more posterior, we see that both jets are fairly significant. It's important also to differentiate PVL from that tissue Doppler or twinkling artifact that happens when ultrasound waves hit a metal stent. And also from sinus of Valsalva flow, which is normal laminar flow that you'll see in the sinuses as they perfuse the coronaries. And this is my simplified criteria for PVL in the cath lab, sort of a modification of the BARC-2 criteria. I look at stent shape, extension into the LVOT, the presence of multiple jets, and the circumferential extent of the stent. The main causes of paravalvular regurgitation are underexpansion of the stent, significant and or eccentric calcium in the aortic valve cusps or the LVOT, a suboptimal depth, too high or too low, or an undersized valve. And the reason why we want to identify the cause is that if it is due to underexpansion, you can see here as we're post-balloon dilating this aortic valve TAVR, that all of a sudden we have better apposition between the stent and the aortic annulus. And you can see the old leaflets being pushed to the side as we have better expansion. So how do we put this all together? Well, this is the initial interrogation of a valve post-deployment. You see the velocity is 3.25 meters per second. The valve looks like a circle, but a little underexpanded in the annulus, and mild transvalvular regurgitation is present. After we balloon dilate, the velocity decreases to a peak of 2.5 or a mean of 11. The valve looks more circular and more expanded into the annulus, and the transvalvular regurgitation is no longer seen. Once we have established success of the TAVR valve, we always want to make sure that we assess for the complications of TAVR. Pericardial tamponade occurs anytime you have catheters in the heart structures, and so it should always be evaluated for. But the main complications of TAVR, annulus rupture, coronary obstruction, significant paravalvular regurgitation, high gradients, have all decreased significantly as valve stents have improved and valves have become safer. And these are the latest percentages from the TVT registry published in 2020. We next turn to post-procedure follow-up of the TAVR. And here, either the next day or at the 30-day mark, you have more time to really quantify and assess paravalvular regurgitation. And here are a number of parameters that you can consider. A reminder that after TAVR, the LVOT measurement changes. The ASE recommends for standardization to use the outer edge to the outer edge of the proximal or the ventricular side of the stent. A successful TAVR is considered a mean gradient less than 20, I would argue maybe even less than 15, an effective orifice area greater than 1.1, and a dimensionless index of greater than 0.35. And this is your checklist of all the items that need to go into a TAVR report when you're reporting on a TAVR at any point after deployment. A quick word on valve and valve. So it's important with failing bioprosthetic valves to rule out paravalvular regurgitation of the surgical valve first. Valves can fail by stenosis, by regurgitation, and sometimes by a combination of both. With valve and valve, the depth of TAVR is critical. If one is using a self-expandable valve, the 80% check is crucial. You want to cover the surgical valve, but you also want to stay high enough that you can really maximize the orifice area, but at the same time minimize the risk of coronary obstruction. A lot of this planning for coronary obstruction is done on CT ahead of time. Just a reminder in the cath lab that the signs of coronary obstruction on echo are acute regional wall motion abnormalities and a coronary distribution after deployment. An early sign of RCA occlusion can sometimes be RV dilation or dysfunction. And I think TAVR really formed the landmark of the field of interventional echocardiography. I think it was with TAVR that there was this recognition that you really need an echo person in the cath lab to help guide these procedures. The other landmark procedure is MitraClip, which grew at the same time as TAVR. And even more so than TAVR, MitraClip is really echo guided. So the MitraClip device is based on the old Alfieri surgical repair, where a stitch was placed between A2 and P2, which improved the coaptation between the two leaflets and reduced MR. And in the old Everest trials, it was really designed for non-surgical candidates. The leaflets would insert on the arms, and then the grippers would come down and really sandwich the leaflets, and then the whole valve would close. The ideal placement for the MitraClip device is A2 to P2. It's the zone that's relatively cord-free. In 2013, based on Everest trials, it was approved for degenerative MR. And in 2019, based on COAPT, it was approved for secondary MR. This is the old iteration of the MitraClip device. The new iteration of the MitraClip device, called the G4 system, actually comes in 4 sizes: a small and a large, and a narrow and a wide. And this is a great graphic from some of my echo colleagues, really kind of describing some of the thinking that goes on in deciding between the 4 clips. And I would say if you look at this and you can review this more, you can really see that most of the characteristics that decide which clip to use are based on echo parameters. This is a nice table of sort of primary versus secondary MR and the indications for surgical and non-surgical candidates. For primary MR, if you are a surgical candidate, the indication is for surgery. If you are a non-surgical candidate, the FDA has approved the MitraClip device, and there are numerous other transcatheter ongoing trials for other devices. For secondary MR, it was always a class 2B indication for surgical candidates. There are also many transcatheter devices, and the MitraClip is approved after optimal medical therapy. And when I assess a patient for MitraClip, I really do it on TE. The first thing I do is I look for their mitral regurgitation, how much it is, and what is the etiology. The second thing I look for is their suitability for clip, leaflet mobility, calcification, presence of an LAA thrombus, which is a contraindication of the procedure. And then because MitraClip is a transseptal access, the third thing I look at is the intraatrial septum. And these are not things that are contraindications to proceeding, but a PFO, severe lymphomatous septal hypertrophy, prior ASD or PFO closure devices will definitely increase the complexity of the case. This is from our ASE textbook on the echo characteristics for MitraClip suitability. It's a nice table that you can go through that basically outlines optimal morphology, challenging morphology, and then what we consider unsuitable morphology for the clip. And so case 1 you see here, live 3D view from the left atrial side of the mitral valve, a very small P2 flail with a very small ruptured cord, an eccentric jet, and clear systolic flow reversal in the pulmonary veins. For flails, I measure their leaflet suitability for clip using the original Everest criteria: coaptation depth, coaptation length, a flail gap, and the flail width. The flail width can either be done in a 3D view or it can be done in a transgastric view. And for this particular patient, they have all the classic features of optimal morphology. And so the decision to proceed with MitraClip is very easy. Let's look at this patient. So this patient has, in this 3D mitral valve view from the left atrial side, really significant bileaflet mitral valve prolapse. All segments are billowing. There is no clear flail, but there are many, many jets of MR. And you see here, the largest jet is this one right here. So what about this case? So there are many optimal features. There's no calcification of the leaflets. There's good leaflet length and mobility, but there are multiple segments. And based on our experience, the patient's comorbidities, we decided to proceed with a MitraClip device, even though multiple segments were involved. These are the steps of MitraClip, and we'll go through these individually from an echo perspective. Once transfemoral venous access has been obtained, the key to MitraClip is transeptal access. And you see here on this diagram of the fossa ovalis from the right atrial side, that the position of your transeptal access really can predict the success of the procedure. For a MitraClip, you want to be a little superior to maybe mid, definitely posterior, and high in the fossa ovalis. And these are just some different other procedures and goals for transeptal access. So how do we figure out where we are in the septum? So you can do this by 3D or you can do this by 2D. The classic 2D views are the bicable view where the SVC marks the superior part of the septum and then opposite to that is inferior. The esophageal short axis view where the aortic valve marks the anterior part of the septum and opposite to that, the posterior. And I think when people think of transeptal access, they really think of these two planes, the anterior posterior and the inferior superior. But there's a third plane that's extremely important when it comes to mitral interventions, particularly MitraClip, and that is the height of transeptal stick to the mitral valve plane. And the reason for that is that the more height you have, the more maneuvering ability you have of catheters and devices before you reach the mitral valve. On the other side, if you're too high, then your catheters and devices may not reach the mitral valve. And so for the G4 system, the optimal length is 4 to 4.5. And that can be done by looking for where the transeptal stick is, drawing a line parallel to the mitral valve plane, then drawing a line from that line down to the mitral valve plane, and that becomes your height. And once we've established transeptal access in our patient, you see here the catheters crossing over. We're using live 3D TEE in that surgical view, and most of the procedure now alternates between 2D and 3D to help guide and then make sure that we have achieved a successful MitraClip. So you see the catheter here in 3D. And our next step is to bring the delivery catheter into the left atrium. The dilator comes in first, the catheter comes afterwards. We remove the dilator and the wire, and we like to have up to 3 to 4 centimeters of catheter in the left atrium. Most of the time it is positioned superiorly, which we will then change when we straddle the valve. And then once we have the delivery catheter, we then bring the clip device. You see that very classic kind of reverberation artifact from the MitraClip. And our ideal position is to position it in the left upper pulmonary vein, and then slowly with 2D or 3D, watch it clear the pulmonary vein, clear the left atrial appendage, and orient towards the mitral valve. And just a reminder on the 3D mitral valve surgical view, this becomes extremely important now as we plan for clip deployment and clip release. And you see here the aorta is the anterior landmark, the left atrial appendage is the lateral landmark. And when we orient the mitral valve in this manner, looking at it from the left atrial side, we have a standard A1, A2, A3, P1, P2, P3. And both the echocardiographer and the interventional cardiologist speak the same language. So now you see that our clip has been oriented to the mitral valve. We have two steps to do here. So first is we want to make sure that the clip arms are perpendicular to the mitral valve leaflets. We want to make sure that we're not grasping a portion of A1 and some of P2 because that would worsen coaptation and not improve it. And then with the G4 system, not only do you have 4 sizes, but you also have grippers that release independently. And so before we go into the ventricle, we want to check and make sure that we know which gripper is posterior and which gripper is anterior. And you see here with this little thing coming down right here, this is the posterior gripper. And that is our check that we've identified the posterior gripper. Now we've advanced the clip into the ventricle. We can do another 3D to just check that the arms have not rotated in advancement into the ventricle. And you can see here that sometimes with advancing into the ventricle, you can get entangled in the mitral cords. There's that sort of characteristic bend of the catheter in the left atrium. And this can take anywhere from a few minutes to a little longer than a few minutes to close a clip down and to gently release tension and try to move this back out of the cords. The easiest approach is to then bring the entire system back into the left atrium, reorient your mitral valve arm, clip arms, and then advance back into the left ventricle. Now I give you this still image because this is what we next need to see when we bring up the mitral clip towards the mitral valve leaflets for grasping. What we want to see is the clip arms here are out. We want to see the leaflets laying on the clip arms almost to the hilt of the device. For the NT, you need about 7 millimeters of tissue. For the XT, you need 9 millimeters of leaflet tissue in each arm to guarantee stability. And I know if the leaflet tips are all the way at the hilt of the device where the delivery system is, that I've achieved that much. You can sometimes linearly measure the amount of leaflet in. You can take a freeze frame capture, and that can give you some guidance as well. Once the leaflet arms are in the device, you then want to see them stable on the clip arms with each beat. The grippers then come down either simultaneously or individually. And when you see the grippers moving up and down, you know that the grippers are moving with the leaflets and therefore they have the leaflets. You then close the grippers fully. You create a leaflet sandwich between the arms and the grippers. And this is what it looks like. So this is our G4 system here. You see that the anterior leaflet is in and the gripper is lifting the anterior leaflet, so we know that we have it. And on the posterior side, you see that the leaflet is into the hilt of the device, and then we gradually release the gripper. We can see the posterior leaflet gripper also lifting right here, and that's how we know we have both anterior and mitral valve leaflet. We close this under color, and as we see the color disappear, we feel confident that we've achieved a good grasp. And from that point on, we then want to interrogate this device before we make a decision to release. We want to look at leaflet insertion, which we can do in 2D or 3D. We want to see a nice double orifice, a good solid tissue bridge. We don't want to see excessive motion of the anterior posterior leaflet next to the clip because that would suggest that there's not an adequate amount of tissue inserted. And we can do this also with some of the newer technologies that are available on the echo machines, including multiplane reconstruction. In the Everest trial days, we would go into the transgastric view to see a gastric esophageal, a gastric view of a double orifice. In current technology, we can do this by a multiplane reconstruction, and we can basically recreate this double orifice gastric view. We turn color on, we see that that very large jet has gone, and now we're left with smaller jets from the mitral valve prolapse. We can check residual mitral regurgitation in 2D and 3D as well. And our next step is to evaluate mitral valve area. We want to make sure that we haven't created a stenosis by improving coaptation. This is most commonly done with the mitral valve mean gradient. 5 or less is considered successful. It can also be done very easily by freezing these views and directly tracing this mitral valve area, basically tracing both of these components of the double orifice. And then here, before we release, we take one more look. We see that the large MR jet is gone. We still have these smaller jets, and we can have a decision-making process based on echo and fluoroscopy, as well as the patient's comorbidities, and whether to put one more clip in or to release this device and end the procedure. Success for a mitral clip is a mean gradient less than 5, and based on Everest trial criteria, less than moderate MR. So I watch now the clip getting released, and I like to watch this in either 2D or 3D. I like to make sure that when we release the clip from the delivery system, it stays stable, and that ensures me that we have adequate leaflet insertion. And you see here the delivery system is releasing the device, very stable device, good double orifice that is still there. In this particular case, given the patient's age, comorbidities, we opted not to put a second clip, and this was the end of the case. The complications of mitral clip are the complications of transeptal access, chordal entanglements, as we saw. Anything where you have a vascular stick can lead to vascular injury, although it's much less likely with a venous stick. GI injury from TE, particularly from a longer procedure. And as I said, anytime you have catheters in any of the cardiac structures, you have that potential for pericardial tamponade. Long-term, it's clip detachment. As you can see here, the clip is detached from the anterior leaflet and is sort of flailing around that posterior leaflet. It occurs 1 to 2% of the time, usually within the first 24 hours, if not the first 30 days. The other longer-term complications of mitral clip include repeat interventions and iatrogenic mitral stenosis, which hopefully you've evaluated before the patient leaves the cath lab table. So let's look at this last case. So this is a patient with ischemic mitral regurgitation. You can see that restricted and tethered posterior leaflet and this very eccentric wall-hugging severe mitral regurgitation jet. So this patient is unsuitable for the MitraClip device based on posterior leaflet length as well as Carpentier 3A movement restriction in both systole and diastole. And so for this patient, we actually chose a transcatheter mitral valve replacement as part of an investigational trial. We've been part of the Apollo trial, which initially deployed a transcatheter mitral valve through transapical access. We actually did our first transeptal access a few months ago, and that is now another part of the procedure. All the planning for the transcatheter valve gets done with a combination of echo and CT. But the main difference between a MitraClip and transcatheter mitral valve replacement is that you're deploying a brand new valve into the existing mitral valve space. And with that, you run this risk of LVOT obstruction, which can be planned for on CT and oftentimes will exclude patients from TMVR if their neo-LVOT, the planned virtual LVOT, is smaller than the threshold size. And this is how the TMVR looks in our particular patient. What's really impressive about TMVR is it's a brand new mitral valve over transcatheter access. This procedure is entirely echo guided. Echo not only aids in the assessment of the transapical puncture, but also in guiding the delivery system into the left atrium, guiding it down to the mitral valve annulus, and then deploying the valve. And transcatheter mitral valve replacement is also available for non-surgical candidates in the valve-in-valve, in bioprosthetic valves that have failed in the mitral position, and also in severe mitral annular calcification. The critical part of these procedures is device position. If it's too high, it can embolize into the left atrium, but if it's too low, it can cause significant LVOT obstruction. And the planning for these procedures is similar to TMVR. It's done with CT in addition to echo parameters. It's very similar to MitraClip in checking for the mean gradient, evaluating for regurgitation, but also sort of evaluating for LVOT obstruction. And the complications of TMVR and valve and severe MAC are very similar to MitraClip with this added part of LVOT obstruction and paravalvular regurgitation. When we first started TMVRs, we did them from the transapical approach. As we have shifted to transeptal, the devices in general have gotten much safer. Valve and ring has also been done, TMVR and previous mitral annuloplasty rings. Just a reminder that not all rings are suitable for TMVR deployment, and those are based also on TE and CT planning. And TAVR and MitraClip, I think, really are sort of the basis of interventional echo. And I've really relied on all the skills that I've learned from TAVRs and MitraClips as we expand transcatheter interventions into other valves. I'm going to switch gears now and talk about ASD closure. This is a favorite topic for echo boards. You see here this ostium segunda mitral septal defect, which, as you know, is the most common type of ASD. It can come in various sizes and shapes, and the surrounding tissue around this segundum ASD is often referred to as the rims. These are the indications for ASD closure. In the 1950s, surgical closure was performed, and in the 1970s, the first percutaneous closure of ASD was described. And there are currently two approved devices for ASD closure. There's the Amplatzer septal occluder and the Gore septal occluder. They both are sized by balloon sizing during the cath lab procedure, up to a maximum of 38 millimeters for the Amplatzer and 35 millimeters for the Gore septal occluder. So as you can see, 35 millimeters is a pretty solid size atrial septal defect that can be closed percutaneously. These are the TEE parameters for ASD closure. So a defect of less than 38 millimeters, because that's the largest that's offered by current device technology, and having sufficient tissue rims and margins. No additional cardiac abnormalities that require surgery. And these are the other parameters that I look at on TEE prior to deciding if someone is suitable for percutaneous ASD closure. So let's go back to our patient. So this is a 3D zoom view of the region of interest, which is the atrial septum. You see here this segundum ASD. This is the aortic valve here, and you see very little aortic rim here. We then use 3D multiplane reconstruction to determine the size and shape of the ASD. This should be done in systole and diastole if there's a big difference between the systolic and the diastolic shape and size of the ASD. In this case, we end up with a teardrop-shaped ASD and the longest linear measurement of 2.5. And that's going to be an important number as we size the device. Our next step is to look at whether a percutaneous device will have enough tissue rim to anchor the device. And we can do this by 3D. This is a diagram from the atrial side showing the different rims that we needed to interrogate. We can also do this by 2D. And so this is very similar to the mitral clip in the different quadrants of the septum. You have the SVC rim here, the IVC rim here, aortic rim, which is the smallest rim, but all other rims look very, very acceptable for percutaneous closure. So when we report out this TEE for consideration of ASD closure, these are all of the abnormalities and the checklist, if you will, of what we need to report. And we can see that for the most part, the patient is a candidate for ASD closure. We note this sort of small aortic rim at 2 millimeters, which is really the borderline for the device. And we chose an Amplatzer septal occluder device. Step one is a choice of TEE or intracardiac echo. Both can be used depending on local expertise. Step two is bringing the wire over the defect. And step three is balloon sizing. And when this balloon is inflated under fluoroscopy, I will also turn color on. And when I know that color has stopped, then I know that we've occluded the device, and measurements are done both in the cath lab on fluoro and also on echo again. Step 4 through 6 are relatively straightforward. The left atrial disc is deployed. The waist of the device sits in the defect, and then the right atrial disc is also deployed. And then step 7 is our echo monitoring of the device. And our main questions are, does the device cover the defect, and is there a residual shunt? And you see here on both 2D and 3D that the device does indeed cover the defect. I like how the proximal part of the device looks on the aorta. It is not into the aorta, it's actually kind of flaring away from it and looks very stable. We then release the device after doing a tug test to ensure stability. We interrogate the defect again with color Doppler after it is released, and we assess for complications. And similar to TAVR, there's the normal flow within the device. There is the residual shunt that you see here. And then there's that twinkling artifact, which is an artifact and doesn't represent a cardiac flow. This is how our device looked in our patient once deployed, a very successful ASD closure. The complications of ASD closure include device embolization, more common in insufficient rims or device malposition or larger defects. Cardiac perforation or tamponade. Long-term complications include thrombus or infective endocarditis. And the most severe complication of ASD closure is device erosion, which is when the abrasive forces of the device lead to tissue erosion. And it is frequently seen on the aortic side. Have a low threshold for investigating this further with a CT or TEE when a patient with a prior ASD closure comes with any of these symptoms that are worrisome. It's been reported to occur 3 days after placement of the device to anywhere out as long as 6 years post-placement. The final case that we're going to review is LAA closure, which is a growing field in interventional echocardiography. LAA is implicated in the majority of strokes in atrial fibrillation, but anticoagulation in atrial fibrillation has its own complications and bleeding risks. And so the basis of LAA closure is if you exclude the left atrial appendage, you decrease the risk of stroke in the majority of patients with atrial fibrillation, and you can safely discontinue anticoagulation. The FDA has approved 2 devices for patients who meet criteria for anticoagulation for non-valvular AFib, so your CHA2DS2-VASc or CHA2DS2-VASc score, and who also have an appropriate rationale to support increased risk of bleeding. They either have a very high has-bled score, they have bled already, they have some reason where they cannot tolerate anticoagulation long-term. But they need to be stable enough to do 45 days of short-term anticoagulation while the device endothelializes. We're going to focus on the Watchman and the Watchman Flex for the rest of this talk. The Watchman and Flex both work using technology that has 3 components to it. So first is this nitinol frame, which is the same nitinol that they use in self-expandable TAVRs that warms in the blood and basically expands, causing radial expansion and radial tension on the left atrial appendage. That's how it holds in place. Then you also have these active fixation anchors that engage with the LAA tissue and also hold the device in place. And then finally, you have a fabric that goes over this. Below the device, the appendage generally thromboses, and then this fabric helps protect that layer until you have an endothelialization over the entire device, and you've effectively excluded the left atrial appendage. The Watchman Flex is a newer iteration of the Watchman and comes in larger sizes. It is fully recapturable and fully repositionable, and both devices are designed to be oversized so that they cause adequate compression and therefore seal the left atrial appendage. The first step is to assess the left atrial appendage to make sure that you don't have a left atrial appendage thrombus. And then the second step is to assess the size of the left atrial appendage. You can do this in 2D or in 3D. This is the old Watchman device. And what you see is that whichever way you do it, you really need to assess the left atrial appendage from 0 to 135 degrees. The 4 quadrants of degrees are 0, 45, 90, and 135. And you measure the width of the device, the width of the ostium of the appendage in all of these views, and then the depth of the device. The Watchman was very cubical, so the depth and the diameter had to be equal. The Watchman Flex is more rectangular, so the depth can be half of the diameter, and it's better for more shallow appendages. Here, when we take all our measurements, the largest measurement we get is 2.7. We oversize, and so we end up picking a 30-millimeter device. The imaging is greatly improved for a left atrial appendage closure. So in addition to being able to do this in 2D and 3D, I show you at the bottom here, you also have the ability to automate it. And some of the software echo companies will actually create this sort of automated software. You take a very nice 3D view of the left atrial appendage, you line up where the ostium is, where you would close that appendage. And then with a couple of clicks of a button, you end up with an LAA area and a maximum and a minimum diameter that you can use for sizing. So now we've established that there's no thrombus. We've established that the size is adequate for a Watchman. And now we want to look at LAA morphology. And why is left atrial appendage morphology so critical? Well, this is a beautiful image from some of my colleagues at the University of Chicago, where they looked at it using the sort of the new glass kind of technology that smooths out a lot of soft tissue and gives you a very good endo left atrial definition to understand lobes. And the reason why is that the Watchman device only works when you have occluded all lobes of the left atrial appendage. And depending on how many lobes there are and where they are, that can help predict the success of the device. So we picked a 30 millimeter Watchman. We know for this particular patient, they have a windsock appendage, which is a single dominant lobe, and they're suitable for the Watchman device. Our next step is a transeptal access. So you see here that it's a mid-septum tenting initially, and we ask that they go more inferior. That's really the preferred for left atrial appendage access. In 3D now we see the catheter directing towards the left atrial appendage. Remember, the aortic valve was up on top. This is our surgical view of the mitral valve, which is also a working view for left atrial appendage closure. You can guide the catheters into the appendage either in 3D or in 2D. And then the rest of the procedure becomes a combination of echo and fluoroscopy, really integrating these two technologies to place this device effectively. And I've just given you an example of, what the corresponding fluoro views are for echo. So the 45-degree view of the left atrial appendage corresponds roughly to the rheocranial view on fluoroscopy, and the 135 view of the left atrial appendage corresponds very closely to the rheocaudal view. So this is our first device that we placed, and you can see that most of the device is out of the left atrial appendage. So this device is true proximal. And so what did we do for this device? We actually pulled it out and started all over again. And when we put the second device in, we liked it better. And so this is how we switch now to interrogating the device on echo before we release it. And the company has really come up with this sort of PASS criteria, which is an acronym for position, anchor, size, and seal. And so what we want to understand first is the device and the left atrial appendage at the right position, sealing the ostium of the left atrial appendage? And are the fixation anchors engaged with the left atrium, which means that when we tug the device, it goes back into its original position. So here's our second device. You can see here the positioning is great. It's right in the ostium of the left atrial appendage. You see here that when we tug the device, it goes back to its original shape. We next want to check compression. So remember, we oversized the device. We want it to be compressed because we know that that's how it stays in place. And the key with compression is that you want to measure it in those four quadrants, 0, 45, 90, and 135, where you see the device to be the widest. And if you see this threaded insert right here, that is your clue that you have a wide device. You're at the maximum width of it. So here on this view, you don't see a threaded insert. That means you're not at the maximum width of the device in that degree and don't measure. And here you do see the threaded insert, so you know you're at the maximum width, and that's where you measure. And there are tables for both Watchman and Watchman Flex that will give you the minimum and maximum compression for the device to scale. And here are the measurements that we performed for our patient with a 30 millimeter device. All of these at 0, 45, 90, and 135 were all within range of 8 to 20% compression. And the next thing we do is we look for the seal or the leak. And here you can see in our particular patient that there is a small leak. So how do we assess leaks? So what a leak is it's a communication between the tip of the left atrial appendage and the left atrium. We evaluate for leaks in all four angles, 0, 45, 90, and 135. You can also do it in 3D. You turn down the color scale to a more appropriate scale for the left atrial appendage. And you really want to measure that linear measurement of the vena contracta. These are guidelines based upon the original data for what constitutes a small versus a large leak. Greater than 5 millimeter leak definitely increases the risk of device-related thrombus and means that a patient may not safely be able to be taken off of anticoagulation. So the complications of LAO closure are device leaks. And again, small ones we don't worry about as much. device thrombus, which you can see here, which occurs in 3 to 4% of patients, device embolization, which usually occurs within the first 24 hours of the device. And there are plenty of things you can do in the cath lab to ensure stability before the device is deployed. And then all of the other complications that are really standard with transseptal access. What I learned from Watchman is also what I apply to all transcatheter cases, which is the difference between optimal, acceptable, and unacceptable. You can see here that you've got optimal Watchman placement here on 2D and 3D. The device is sealing the left atrial appendage at the level of the circ and about 2 centimeters down from the tip of the Coumadin ridge. And you see here in 3D that the entire device is sealing the left atrial appendage. Then you have the acceptable Watchman placement. So here you have a device that's a little bit more proximal, has a small mitral shoulder, but is still sealing the left atrial appendage. Here you have a device with a small leak, but is otherwise very, very stable. And then you have the unacceptable placements. Here's a device that is mostly out into the left atrium. We don't expect the anchors to be engaged, and we don't expect this device to be stable. Here you have a Watchman that looks really beautiful on 3D TE, but there's a large lobe of the appendage that is not covered. And then here you have a Watchman that is actually sideways. It's canted into the left atrial appendage. The fixation anchors that are out here are in no way engaging with left atrial appendage tissue. And this should also not be left in place. In conclusion, interventional echo is a growing field. You can expect to see more and more questions on echo boards as these technologies mature. For you in the field of interventional cardiology, I'll just leave you with these key points. Pre-procedure planning is critical, and it is often multimodality. A target transseptal can either make or break the procedure. What I've learned is the difference between optimal versus acceptable placement, really tailored not only to the device, but also to the patient and their comorbidities. A rigorous intra-procedure assessment can save complications later. Always have a high risk or high threshold for considering pericardial tamponade in patients who are unstable. There's definitely a learning curve, and the more you do transcatheter procedures, the more confidence you'll gain. What I've really enjoyed about the field is the new and expanding indications and the ability to offer people who are not surgical candidates choices and options. And what I've also really enjoyed about it is the new expanding technology. Echo technology has definitely improved and is really geared now towards structural cases. And I've tried to highlight some of the newer technologies in this talk. Thank you.